Welcome to our recording for this week. This week we are looking at three different categories of diagnoses. We are looking at trauma and stressor disorders, dissociative disorders, and somatic symptom disorders. So for our first category, our trauma and stressor-related disorders, this is going to include disorders in which exposure to a typically a traumatic event for our major categorical diagnoses such as PTSD, or a stressful event is listed as a part of the criteria. So this is a category of things that cannot be diagnosed unless this kind of event has taken place. You might notice that there is a close relationship to anxiety disorders, obsessive compulsive and related disorders, and dissociative disorders. So these are going to be fairly close to this category in the physical copy of your DSM. But it's also closely related and also sometimes very comorbid. So you might see a lot of overlap where people have multiple diagnoses. Our main things that we're going to be looking at here is our inability to experience pleasure, that sense of unease and dissatisfaction, and a lot of symptoms that externalizing angry and aggressive symptoms and dissociative symptoms as well, even within this category before we shift over to the dissociative disorders. So again, this is set up in kind of that lifespan setting, so that things that happen earlier in life is going to be at the beginning of this section. And this is one that definitely fits that. So reactive attachment disorder is something that we're going to need to have some kind of disturbance before the age of 5. And this is typically going to only be diagnosed in younger children. You occasionally see this and slightly older children, but it still has to have the disturbance before the age of 5. And in this specific category, we tend to see more incidences of neglect rather than specific kinds of abuse. So a child will have gone through some kind of consistent pattern of inhibited, emotionally withdrawn behavior towards the adult caregivers. And a big part of that is because of the trauma, and it couldn't be from a different caregiver, but there's going to be a really huge issue with the attachment. And that attachment is that key feature for reactive attachment disorder, that the attachment to the adult caregivers is either absent completely or grossly underdeveloped. And this is going to come out of that disturbance of some kind of pattern of insufficient care. So neglect, lots of changes in caregivers at times. So if a child from the time that they're born is shifting from foster home to foster home, that shifting of caregivers does not allow them to have proper attachment to one individual, which is really, really important, especially in that first 2 years of life. So that emotional regulation capacity is going to be compromised. So when we talk about our neuroscience piece, depending on which classes you've taken at this point, we talk a little bit about the mirrored neurons and how one of the ways a child will learn to develop skills in emotional regulation is by watching the adult and seeing how they react to different situations. And if the adult is able to react in a calm and positive way, that teaches the child how to do the same thing. So without that ability to develop mirrored neurons and learn from other people's behavior, we have issues such as reactive attachment disorder. This can co-occur with developmental delays, cognitive and language especially, which kind of makes sense if you're thinking about the age of the kids and how they're not getting the interaction that's needed. We don't really know the prevalence is pretty rare. I actually think this is one that is overdiagnosed, because even in severely neglected children, less than 10% of the kids are going to end up having a reactive attachment disorder. But it seems to be a label that people like to throw around as a young child. They're not attaching to their parents or interacting with their parents in a way that they prefer, so suddenly they think there's a diagnosis of Rett. That's not always true. So keep in mind that there may be an overdiagnosis of this. So if you have a child come into your office that already has this diagnosis, I'd be a little bit skeptical, and I'd spend a little time kind of exploring if this is really the best diagnosis. The one that you probably all know the most from all these categories for today is the post-traumatic stress disorder. And this is one that is going to be directly related to having that traumatic event as it is defined in the DSM. Um, we're going to look for symptoms including intrusive thoughts, dreams, disturbed sleep, perhaps dissociative reactions, and that's where our flashbacks come in. It's a form of dissociation where they don't understand that, or it doesn't feel like at least, that the event that they are remembering is in the past. It feels like it's in the present. So that is a form of dissociation. There's an avoidance of triggers, hypervigilance, lots of different symptoms. I don't think any of those are new or a surprise to you. That includes that characterization of a heightened sense of sensitivity to potential threats. There are some different criteria for children younger than 6, so make sure you take a look at that if you are working with the younger folks. But this can occur at any age. And also with those younger children, you might see some forms of regression, such as that loss of language. It is interesting that there is a huge discussion around complex PTSD or CPTSD, which is when that abuse is taking place over longer periods of time and involves a close relationship. So typically that is thought of as a child to caregiver relationship. It could also be some kind of interpersonal violence taking place. So it could be between 2 adults as well. Either way, if we have that intensive relationship piece, that's when the complex PTSD comes in. That is not a diagnosis in the DSM-5. There was a big discussion about adding it to the DSM-5, and it didn't actually take place. And I think that is one of the biggest failings of our new version of the DSM in the 5th version. Neither the 5th or the TR has included this. Complex PTSD is, however, recognized in the ICD-11. So if you really feel that is the most appropriate diagnosis and you're in a system where you can work with the ICD instead of the DSM, you might be able to use that. One of the reasons why I think that might be important is because neglect does not fall into a post-traumatic stress disorder category. So even if there is a lot of disturbing reactions from the individual, if the event was neglect instead of abuse, you're not able to diagnose PTSD. Some alternative diagnoses might be adjustment disorders, that complex PTSD, if you can use the ICD-11. Borderline personality disorder might be one to explore, and other trauma and stressor-related disorders, which is not one that we are going to specifically look at today, but that is one that you could categorize an individual with a primary issue of neglect. Oh, I forgot that we had another slide. Okay, so lifetime prevalence is about 6.1 to 8.3%. Every 12 months is about 5%. There is a slightly higher rate of PTSD in females, and I think there's 2 things that might account for that. I think one of those is that men might be underreported. Women tend to come forward for therapeutic support a little bit more often, so that might be one of the reasons. The other is I do think there is more forms of violence that is often perpetrated higher, more often, more frequently in females than men. Not that it doesn't happen to men as well, it just happens more often with females. Make sure that you screen for suicidal ideation and suicidal attempts. There is a lot of issues with PTSD and suicidality, so make sure you're doing a really good, strong assessment for that and you're checking back in with your clients. You might also notice high levels of social, occupational, and physical disability and a high rate of medical utilization. Also keep in mind, we are going to have lots of other co-occurring diagnoses with this as well. So individuals with PTSD are 80% more likely to have symptoms that meet criteria for at least one other disorder. Substance use and conduct disorders are going to be more common in men or males. We're also going to see a lot of anxiety and depression in everyone. So just a couple of things to keep in mind. I'm honestly kind of curious as to why they didn't put this before PTSD, because that would have made sense to me, because time-wise, we are looking at if we are meeting with someone really quickly after the event, 3 days to 1 month, then we're looking at acute stress disorder. However, the same symptoms for longer than the month, longer than 2 weeks, actually, we're gonna flip into PTSD. So I think I would have put this before, but that's okay. So we are looking at some kind of an anxiety response that includes some form of re-experiencing or reactivity to that traumatic event. And just like PTSD, it's going to have some similar symptoms, being, including having that heightened sensitivity to potential threats. A little bit more common in females, again. And also, we're going to pay attention to, with this as well as everything else, some notes on specific cultural symptomology. So I will let you take a look at that on your own. One that we might use quite a bit is our adjustment disorder diagnosis. So our adjustment disorder is when there is an emotional or behavioral symptom based on an identifiable stressor or stressors. So this does not have to be trauma, it can be a form of stressor. It will be something that the reaction is out of proportion to the event or causes a significant impairment. So we would often say for a lot of these different variations in trauma, it is not out of proportion to have a big reaction to a traumatic event, but it can cause significant impairment. So that might be the side that we're looking to a little bit more strongly. Not related to other mental health disorders or bereavement. Remember, there is specific diagnoses for kind of that prolonged bereavement or grief. And we're going to use other diagnoses for a mental health disorder if we can find one. Symptoms are not lasting longer than after 6 months of the event. And again, keep in mind you need to do some good screening for suicidality. This is actually fairly common and can be comorbid with other disorders as well. The one thing we've talked about a little bit, and I continue to think about, is if we are working with people and we're not quite sure what the diagnosis is, but we have to give them something because they're, for insurance purposes, the first time you meet with someone, you have to give them the diagnosis. And if you're looking at some pretty severe forms of diagnoses, you might want to shy away from that until you get to know the person a little bit better. I'm really not comfortable giving people a lot of these different diagnoses if I've only met them one time, unless they already come in with paperwork from a physician or a psychiatrist or something like that. So this is a nice one that does not have that stigma, and really pretty much anyone could fit into having an adjustment disorder at some point in time. So the stigma part is not very strong for this, and that's one of the things that I really appreciate is that we're not going to have issues with people having an adverse effect with having this in their paperwork for later on. It's something that you can start with, and then once you have a couple more sessions with the individual, you can switch that diagnosis to something a little bit more specific. So just an idea there. Okay, moving into our dissociative disorders, which we're often going to find after some form of trauma as well. That's part of why it's that close to the trauma and stressor category in the DSM-5. These are going to be characterized by that disruption of and/or discontinuity of the normal integration of consciousness, memory, identity, emotion, perception, body representation, motor control, and behavior. So dissociative identity disorder is probably the one that you hear about the most, even if it's not the one that you will see the most, because it tends to be something that catches people's attention and people really are interested in it and find it fascinating, which it is. But also be careful not to overdiagnose just because it sounds interesting. This is replacing the multiple personality disorders that we saw in the DSM-4 and earlier variations. Our defining feature for this is the presence of 2 or more distinct personality states, or there could be an experience of possession. And we do have a note that this would be something that's not a normal part of a broadly accepted cultural or religious practice. So there are cultures in the world that might have a religious practice that involves a possession. That would be something that you are not going to diagnose as a dissociative identity disorder. It is associated with overwhelming experiences, especially traumatic events, and especially within that abuse during childhood. Very often comorbid with depression, anxiety, substance use, self-injury, and seizures. And what we're going to see a lot of is people who are trying to hide that they're having issues with this. So the part that often comes up the most for people when they don't know that they have this diagnosis is kind of a missing time. So we might have a person who has, let's just say they have one other personality, and their alter takes over at certain points of time, and that primary identity, primary person cannot remember what happens when their alter takes over. So you're going to have some time gaps in their mind where they don't know what happened. Maybe they wake up in a different place, or they are suddenly wearing different clothing, or have their nails painted, or whatever. And that is very disturbing for people. They often don't understand what's happening. So when that is going on, you might see people trying to hide what's happening and hide those time gaps, make excuses for themselves. And then later on, they might figure out, or they might be in treatment and find out that they actually have another personality that is taking over during that time frame. Lots of suicidality in this as well. The prevalence is listed as 1.5%. I really think that's kind of high as well. So again, people think this is kind of fun and flashy, so they sometimes overdiagnose this, but it's really, really not that common. I've had one person in my therapy office that said they had this diagnosis, and I did try to work with them as far as giving a little bit more grace, but they would miss multiple appointments because I knew that this was something that they came in saying they already had a diagnosis of. I was giving them a lot more grace as far as rescheduling appointments, not having any penalties for missing appointments, that kind of thing. But it was only, I think, 3 sessions, and then they just kind of disappeared and didn't return phone calls or letters or anything. So I didn't really get into the treatment enough to see any of the symptoms of this. I've known a couple folks in my personal life that have said that they have this as well. But again, it's never been something where I've actually seen the alters. Um, I do think it actually does happen, but not as often as we think it does. In the past, there have been some trains of thought that question if this is even really a diagnosis. So again, I think it is, but I do think it's overdiagnosed. The other that you might see, although I don't think I've ever actually seen this in a significant manner, is simply having an inability to recall important biographical information that would usually be remembered. And this can be around a specific event, or it could be around a specific part of time in life. So maybe a person just doesn't remember the one night when something happened, if it was a one-time trauma. Or maybe in their life history and their identity, there's a whole year that's missing because looking back, there was some stuff going on, say, during 4th grade, so they don't remember their entire 4th grade year. Onset is usually sudden, and people can have multiple episodes. So be aware that that is something you could see in the office, that people really do have blockages in their memory, and that is a protective factor that your brain is doing for you. So I would kind of frame it in a more positive way. Hey, look, your body's protecting you. That's great. We don't have to force the memory to come out. We can work with the symptoms of everything else that's happening around it. Okay, last category for today is our somatic symptom and related disorders. This is a new category in the DSM-5. They share a common feature of a prominence of somatic symptoms associated with significant distress and impairment. So this is where people might have a headache or a stomach ache or kind of that all over pain or fatigue or something like that. But again, it's significant enough that it's causing problems in the person's day-to-day life. So this is not, I had a really bad day at work and now I have a headache. That is the kind of symptom you might see, but it's going to be ongoing and it's going to be enough of a problem to cause that impairment. Again, high levels of comorbidity with other mental health disorders and medical diagnoses. Probably the most common one is a somatic symptom disorder. This is something where the somatic symptoms that are distressing or result in that significant disruption of daily life, just like we were talking about before. Typically, they have multiple or current somatic symptoms. Could be one severe symptom, usually pain, and that could be something specific like a headache, a stomach ache, shoulder pain, or it could be kind of vague like fatigue. We were talking in one of our classes about this just diagnosis a while ago, and we talked about how some of that you first of all absolutely want to make sure anyone that comes in with this kind of symptom goes to a medical doctor and gets screened for any of the issues that might be coming about. But it could be something that there isn't a medical diagnosis for, or people are not able to get one. We were kind of speculating in our class that maybe some of the diagnoses like fibromyalgia or lupus, things that have kind of unusual symptoms and are sometimes not diagnosed very well by medical doctors, could be a part of this. But again, we want to make sure that the medical side is taken care of by the physicians as much as it can be. And then we're going to work with the coping skills. So even if it is, say, fibromyalgia instead of somatic symptom disorder, we're going to work on coping skills for that distress and that disruption that's happening. You will see lots of depression along with this diagnosis. And kids, we're going to most often see symptoms of stomach aches, headaches, fatigue, and nausea. And we really don't know how often this happens. It might be around 4 to 7%. Illness anxiety disorder is that preoccupation with having or acquiring a serious illness. And there may or may not be those somatic symptoms. If they are, they're not going to be the main issue. It's going to be something that's only mild in intensity. It's going to be more that worry about that mild symptom turning into a severe illness. They can be easily alarmed about illnesses, such as hearing about others falling ill or news. So you can imagine there was a lot of issues with this during COVID. It affects daily activities. So again, it has to be fairly severe. It's impacting you, probably restricting you from doing specific activities. And again, we really don't know how often this happens. The previous variations of the DSM call this hypochondritis, and that's no longer a diagnosis. So we have different criteria now for the illness anxiety disorder that doesn't necessarily translate. So we don't know exactly how often this happens yet. Factitious disorder is that falsification of medical or psychological symptoms. So this is where we're going to have a persistence of behavior to conceal the disorder behavior with identified deception, sometimes to the point where people are seeking treatment for an issue. So this is where people want the attention and they want other people to believe that they are sick. So they might be acting ill, or they might even be causing illness. So they may be taking like small doses of poison so that they have certain symptoms that then they can show up to the doctor with. And then they might actually be getting treatment for that medical issue, even if they don't actually have it. This is not something that happens very often, usually developed in intermittent episodes. There is another variation of this, which is called factitious disorder imposed on another. This used to be called Munchausen by proxy, or if it was for yourself, not being done to another person, Munchausen instead of factitious. So we do have some situations where usually a caregiver will be causing harm to another person in small doses, such as that poisoning, to make that other individual seem ill. And again, that individual might be receiving treatment for the supposed medical issue. So this is a variation where the adult caregiver typically would be seeking the attention and the sympathy of other people because of what's happening with the person that they are presenting as ill or injured. Okay, I believe that is all for today. Yep, so that is the end of our discussion. Thank you for joining us, and we will start with our next category next time.